yeah. There you go.
Morning, everyone. I am here. Today I am going to present my exam. Thanks for joining me. This is EKG.
Okay, traditionally from the people who sit down close the screen. So, Indari. Whatever you can do. It's just a tradition. Okay. Yes.
No pressure. You just read it. Okay.
There's written. Reading EKG.
Why do you think it is PVC? Could you speak louder? Because the microphone is here and you're talking, everything is recorded. And we will upload it.
Stand up and touch.
Yes.
Okay. It's in PV. I think it's that's the same equation. Then later, going to the dog goddess conflict. Meaning PVC.
So why? Just why first? That is not enough to determine PVC.
So you're free to read the EKG. Okay. Then no, that's you have not done yet. You're not finished yet. So listen. Yes. So you get in there. Now listen. EKG, you read it systematically. So we're trying to teach you to think. Okay. It's whether wrong or right doesn't matter. But how do you develop your own way to read the ECG every time consistently? Okay. So you studied very well. P wave. So what's the P wave looks like? Normal or abnormal? Normal means sinus. You assume. Okay. So you read the specific terminology, sinus rhythm. Okay. So baseline rhythm of this ECG is what? Sinus rhythm or not a sinus rhythm? Just looking at the P wave, right? How about PR interval? Normal, abnormal? Okay. So PR interval normal means what? Normal aviodynamic conduction, antegradally, right? Correct. How about the QRS? Not the big one. I'm talking small guy. I want you to tell me that. What do you mean normal? Is the X is normal? QRS? 2-3 AVF? Why the Q? What do you read in your cardiology when you see Q wave in 2-3 AVF? It's a QS. There's no R wave. And what else? And then you look at the next is a SC segment and T wave, right? Is this normal? Okay. And then T wave is inverted, right? What does that mean? Huh? If there is ischemia or maybe whatever, injury previous, whatever you talk, okay? So this is not normal ECG. You cannot call this normal ECG, right? So those are important. Then you construct your argument. You just describe it, PVC. So next question is PVC has any pattern that you see? So Dr. Park question is why the PVC? Okay. So then you have to find what? If PVC happen, follow the PVC, there is what? Why the RR interval is longer? You see, there's a PVC, bottom, lead 2, look at the lead 2, bottom, after PVC. Sinus rhythm came on time,
Yes.
you think? Longer? I think that's Dr. Parker leading the question.
Oh, okay, please sit down. Please relax. So,
We are not trying to stress you.
yeah. Don't get stressed. Okay? Padma?
Normal sinus rhythm with PVC and PVC V1 morphology plus RBB morphology.
No. Before decide PVC,
He wants to know why.
so please
Uh,
decide whether it is real PVC or there is other kind of wide cross complex such as excitation, aberrancy, or pacemaker rhythm, whatever. So why do you think it's PVC?
After the premature complex compensatory pause, there is
Okay.
compensatory pause.
So I'm not sure this PV shows compensatory pause or not.
Caliber.
The Q, can you measure on the screen? Use your caliper. Oh, you didn't bring your weapon. Compensatory pause means the narrow cross alloy interval, including PVC, is exactly twice to the regular narrow cross interval, right? The reason why PVC, if PVC does not reset the sinus rhythm, it is exactly twice interval, right? But I'm worrying, I'm curious because after wide cross complex, there's small P-wave like notch.
Yeah.
So if the PVC conducts retrogradely and reset the sinus rhythm, it can break the rule of compensated pause, right?
Yeah.
Now, one thing that you need to understand, retrograde
No
P,
compensation.
right? Retrograde P wave can reset, may not reset the subsequent P wave activity. Because if you have a P wave, retrograde P, has an entrance block to the sinus node because of perinodal tissue block, then sinus will fire on time. Okay? But however, if the retrograde P wave penetrate to the sinus, depolarize prematurely, then you have a non-compensation. Okay? This is important concept. You guys need to read the book I gave you. Charles Fish described this very well. Okay? Go review today. Sometimes we read it once, you forget. You gotta start time to time read again. That's why it's still in your brain. So this is what we're talking. So your assignment today, look at the sinus node chapter of Charles Fish book. We gave a PDF file.
Yes.
You're supposed to read all that. So, okay.
So because there is no preceding P wave before the wide cross complex, and it looks like the retrograde P wave, so it is more likely, highly likely PVC, right?
Right.
And then next, Josiah,
Okay.
can you interpret the narrow cross rhythm? Not PVC. Is it normal or abnormal?
Regular rhythm after the 75, I think it's a normal sinus rhythm. Also, PR cannot is normal.
And how's the limb lead axis and the precordial lead?
Normal sinus rhythm axis left activation.
How do you think limb lead axis? Lead on positive, 2-3 ABF negative Q wave, right?
Yes.
Is it normal?
That inferior lead to the negative whereas this patient has some MI or some infarction before.
Okay, so
Inferior.
it looks like a passive Q wave. So
Pathological.
even though you guys have the EP, but you should be carefully watching the normal currents, right? Okay, Kofi, your turn.
Okay. So as has been said, it's a sinus rhythm with a left axis deviation and Q waves in leads 2-3 AVF. There are PVCs. Yes, so there are PVCs quite frequent, alternating after 1 or 2 normal sinus complexes. Looking at the PVCs, they have a negative polarity in the inferior leads, which suggests that they are moving from the bottom of the heart upward. And then in V1, it has a negative polarity, suggesting it's coming from the right, but it transitions sharply in V2. And there seems to be a bit of a pattern break in V3. The R wave of the PVC is shorter than that in V2.
Okay, I'm sorry to disturb. Please define the pattern break for other fellows.
So normally, PVC morphology transitions gradually. So you would either see that the S wave deepens as it goes on, or the R wave continuously increases, just like how we have R wave progression. But we have a pattern break where a preceding lead has a taller R wave or a deeper S wave than the lead after that. So in this case, in V2, there's a significantly tall R wave, but you come to V3 and the R wave is shorter. So that's the pattern break.
Okay, what does it mean?
Normally it means that it may have, I think it's related to an epicardial or a summit position, but this doesn't fit that morphology.
Okay.
So question asking is that when is that the most likely pattern break to happen? What structure in the heart involved? This you guys need to understand. Okay? Why V2 is the tallest? Lead V2 has to be looking direct to that focus. Okay? And V1, V2 is not. What does that mean? What does the V2 mean? EKG. It's a 12 ECG basic lesson now. What is the V2 is looking for? V2 is a septum.
Yes.
Right?
On the left, yes.
V1 is the right, V2 is the left. V2 is the septum. That's coming from posterior anterior orientation vector to septal activation. Okay? Yes. So that means this is coming from where? You told me inferior base septum. So what that it is? Crux. Easy enough. Same as the PVC interpret RVOT. Coming from septal side, you expect this pattern break, particularly when the left side. Okay? Because LV septum is a thicker, stronger than RV septum. All these things you have to think as a anatomy. So it's not that difficult to understand that. And Kofi discussed that notching at the terminal R wave in the V2. Why that? And the V3 is a Q, right? I mean S wave, same thing. And then limb P1 does not have it. So what they mean? So terminal portion activation first is turned around, down and up again. Okay? So where there could it be? Kofi, you just mentioned briefly. Epicardial cross does that. Okay? So is this something that you need to watch closely?
The question is more and more difficult. That's why the early read.
Yeah. So no, it's meant to exercise your brain. We are trying to educate you guys. So now, if this is indeed crux PVC we're discussing, V1 as an R wave, is it possible? Right, you can have it. So early paper described this as perhaps a left bundle branch block pattern across PVC. And you guys are experienced fellows, you guys have sent many cases. Where does the cross you think it should ablate it? Or should I think about it? I'm getting a little more now deep diving to this business. This one doesn't have R rate. Remember we just talked briefly? QS, leader 1 to 3 has no R rate. Okay? What do you think? This has to be probably inside the MCV or either, or maybe left side. So when you have a tiny R rate, we discussed it. Favorable couplate from the right side, posterior superior processing or under trapezoid valve. When you have no R rate, right at the middle of MCV or left side. Okay, this is a Scheinman's paper, 2014. That's why, most center study, they describe it should ablate epicardial, non-epicardial, no sense. Teaching point, the bottom line is, cross PVC these days, we don't ablate nothing in epicardial. Don't even think about epicardial. We can all ablate endocardially if you map carefully. And then also, since 2014 now, we have many more powerful tools to ablate, irrigation catheters and all that stuff, and also high resolution 3D mapping facilitate our life so much. So that. Now, next question. What's the differential diagnosis here? You only think of cross PVC. Less likely, what other structure we need to think?
Yeah, it is different to the idiopathic cross PVC.
Right.
Because it shows their
inferior mind.
eye, so it could be related to scalp.
Right.
Scalp border joint.
Then what else? Any structure can give you this close enough, similar to this? Very rarely, inferior papillary muscle of the tragus annulus can give this. Okay? So you must differentiate. You have tragus valve, have 3 papillary muscles, right? You guys only study septal and anterior. That most commonly talk about. There's inferior papillary muscle structure called.
Do you mean RB?
RB, tragus, because right under tragus valve.
But it isn't too early transition.
Yes, you can, because it depends on papillary muscle where exit, where the case. That's why I'm just discussing. Very rare, but it's happening. You need to be careful. Because the only reason I say this because the QRS is a relatively narrowish looking. You see, even the crux septal PVC, crux usually tend to be wider. This is narrow. That means it's embedding conduction system fairly early into the activation. Otherwise, so anyway, anything else you want to add? The key point today.
Anything else?
No
Junyoung,
question.
why you are always sitting back seat? Okay, question, please.
Given that the intrinsic deflection of the PVCs is quite narrow, especially in the precordial leads, can we also consider a conduction system origin?
Probably not. The reason is why. If you have a conduction system involvement origin, you should see what structure you're talking. Could it be right bundle? But then right bundle and where? Anterior papillary muscle, moderate band, right? So it's more posterolateral orientation, not the posterior orientation. Make sense? They should have R way, not QS. Okay?
Okay. Yeah. Okay.
Make sense? Yes.
Yes. Okay.
Good question. Okay. So think when you interpret the ECG, it's important for you to remember cardiac anatomy and try to correlate. That correlation comes from where? Your patient examination, because every heart patient different. Okay? That's why you need to listen to the heart, palpate the heart, where this thing is. You guys learn how to palpate the PMI in medical school. That tells you how much your heart rotates, not rotating. Didn't they teach you this? When you precord it with the rotate laterally, this heart is deviated. Why teaching you that? Because that's the reason. Your diagnosis should be thinking when you examine the patient, listening to the heart and palpate the heart, then you have already idea. RV enlargement, PMI, dislocation, and so on. You guys don't practice this kind of medicine these days. That is a sort of a major deficit, unfortunately. Appreciating patient's heart in examination, so much important. When you interpret the ECGs, help you so much. Then integrate all the information together. So that's why, all the mentors insist to you guys carry stethoscope, listen to the patient, examine the patient. We are not telling this for no reason, okay? If you based on all the stethoscope without ultrasound and all that, you will send loads of sense of a clinical touch. That would be a major handicap in your clinical practice. I can tell you that.
Okay, Dr. Huang Jr.
Okay. I'm glad you're junior, not me.
If you decide to back and ablate this patient, what is your strategy? What is your plan?
First, I will let the right ventricle make the geometry with the grade over Arcone trail. I will use 3D activation map from the RBD first, and then we found that also I will make the geometry of the CS. I take atrium and then any kind of structure put that. Try to find out the only activation points in phase mapping. If there is no good points, then I will go to LB side and then find classical mapping, then try to find out the best point.
So RB RA mapping first.
Yeah,
This was
That'll
the
be later.
Professor Yu Tet right there. The Master Yu Tet. Would you do anything more than that? What is the most important thing here right now? Even the patient clinical symptom, probably palpitation or something. So, first thing what you should do before you match. Do you want to assess patient to the electrophysiologically first, perhaps? If this patient had the inferior MI, what's your concern?
Oh, before I EP study, I do.
Right, you got to EP study this guy.
Yeah.
Make sure he's not inducible sustained monomorphic DT. The basic things first, okay? Because patient has an inferior QS, T-wave inversion. You could argue that could be cardiac memory, but I doubt it because the QRS is a QS. I want to know what the PVC, potential PVC trigger can do. Can you induce PT in this patient, right? Isn't that the PVC does? The trigger? That's what you guys ablate all the time. So this is not a normal patient. It's a structural heart disease patient. You better do EP study, full EP study before you ablate this thing. Make sure there's no inducible VT, patient is safe, then you can do whatever you want to do, okay? The fundamental thing is that first approach is a very important concept. There again, clinical history, your physical examination all put together, and then you evaluate the patient, decide what I'm going to do in my EP lab.
I fully agree with you, but
Yeah.
not 100%.
Why?
So my policy is during EP study and anything, sometimes you will lose the PVC, like yesterday's
Wow.
case. So whenever I see they try to ablate the non-sustained VT or PVC, if there's PVC, quick map as soon as possible and targeting, then you can do the induction study, but the PVC hide very frequently.
Well, that's his experience that the two things. Whichever you want to do, you want to have a complete information base. Okay, so if patient has not had a syncope or anything like that, that's a clinical judgment. You decide to do study later. But the bottom line is that we need to study. The way I learn, we do EP study first. That's what I learned from my mentors. My mentor would not let me ablate anything unless I do full EP study. Okay, and typically, I can tell you, structural heart disease related PVC, they don't disappear. Idiopathic PVC may. That's the difference. Okay? So you have an inferior MI patient indeed. You think this patient is going to go anywhere? I don't think so. Very unlikely. That's our experience. Because we used to do many trial early days. We did not have ablation capability on the DC shaft.
We don't know this PVC is coincidentally EDFS PVC.
Could be,
Yeah.
but that's I'm just trying to probability wise. Okay, we don't know any of this stuff. So as I said, we're not telling you what to do. We are suggesting. So each one decide what they think is right.
Okay, let's compromise.
Okay.
If you see the PVC map, then the delay the population and full study, then
Mhm.
oblate.
Well,
It's-
is it
It's
possible?
okay?
Yes, but I think not how I do. Unfortunately, my ways works though for me, but it may not work for all of you. So again, I tell you before, take only what works for you. We just suggesting. I'm just clinical observation. I'm just giving you experience. That's all. We are not demanding you do the same thing. Okay, this is important fact that you have to take a message.
And then regarding the RV mapping first, because this patient QA
Right.
I strongly recommend robots map RV and LV together.
I think FCV probably, yeah, you can get with it. Because it's you can ablate from RV, it will have a slight R wave into the AVF, as I said. So, okay. Why the complex QS? That's the worst because you end up going to the left side or mapping all over the place. Okay.
How much?
I'm not, either stats by Dr. Yui Tae over there.
Just
Just
medically.
that's the reason. I see. Oh, is it not? You don't read.
First
Sorry.
time to see this.
I thought that you guys read your own ECG.
Whose case is this?
Yeah.
Yeah,
Whose case? Oh, his case.
The PVC sideways, forward way.
Oh, disappear? Oh. And it looks like a, interesting EKG and relatively narrow. I think it's a good thing. That, I'll probably be back. I'm sure.
okay.
Anything else?
I have a question.
Yes, please.
Um,
You have a question for him? Go ahead.
there was this one patient. He had half rep with a history of headache.
Yeah.
And he had basal PVC, basal crux PVC. And this patient, I ablated it from the RA side,
Mhm.
and it disappeared very
Quick.
Yeah, very quickly and like in 1 or 2
Mhm.
seconds. And I mapped the RV and the MCV, and the early site was from the RA side, so I ablated it, but he's now recurred.
Okay.
Yeah.
The question you have to look at your EGM. So your ablation signal, you ablated, is a far field signal from the local onset EGM. It's particularly more than 10 milliseconds. I recommend you map other side as well for your blade. I think it's a golden rule of a PVC ablation, whether outflutter or whether LV or RV, doesn't matter. You need to look at the unipolar always display plus bipolar. Unipolar will detect earliest far field signal. In that case, will coincide your far field of your bipolar signal. But your bipolar EGM from onset of a sluggish far field to the local sharp activation time, measure that. People don't sometimes look at those things, but if you look carefully, is less than 10 milliseconds, reasonably good target of like that. But unless you have a really very sharp local bipolar with quick drop of unipolar, really reflecting this is a typical source of that, usually you should be successful. But then if you far field signal is only just more than 10 milliseconds, I typically try to map other side before you decide to play. Because you're looking at probably some percent exit site or either tissue sources or deep, that might be the earliest site you think. But in reality though, took a 10 milliseconds to far field to reach the catheter. So I think 10 milliseconds has been sort of a no published data on this, but it has been somewhat golden rule for me. So I always tell my fellows, yeah, let's take a look at the other side, make sure that there's enough earlier this tablet. Second, if you far field the mean, that also allow you to determine your energy level. Or you're going to ablate the safe area, let's say 10 millisecond early far field versus near field. Near field, you can ablate 25 to 30 watts, no matter what irrigation, you're going to get rid of it right away. But if you far field early, then you may end up doing high power ablation. Sometimes we don't have even no near field signal, all far field signal. Then we end up ablating high power, 50 watts for 2 minutes or something like that. But you have to have specific orientation of your energy going through that site. That's why Dr. Park, many of us use a two-frequency catheter into deep tissue and then target that as a reference anatomic ablation. So those have been helpful. And some people argue even small two-frequency electrode compared to the surrounding cardiac tissue drops the impedance a little bit, the energy preferentially target toward that electrode. There's a many paper going on published right now, and they're putting a microelectrode catheter puncturing needle, the septum, inserting two-frequency multi-electrode catheter, targeting the sequentially for septal ablation, PT ablation. So those are principles behind it. So I think it works in many cases. So that's how always we argue, Dr. Park and I. 45 watts, 50 watts. So Dr. Park wants a high power. We worry about the little over 45. But in reality, not much difference. Not much difference. Okay? There's not much difference. I think we don't know exactly what is the energy truly delivered to the site, unless somebody put a temperature monitor or something in there. But we don't have idea. And I think technology should develop. And then also argument about some groups say 5 minutes long, some people say 2 minutes long, some people say only 90 seconds, something like that. It's all arbitrary based on the. But again, just comparing TBC and then at mathematical energy level, not fair, because every heart different. So we are comparing apple and orange here. So I think like my experience versus my experience could be very different. I used to ablate big guy, big people, American people, Korean people smaller, Asian people smaller. So it works better as well. So I think that might be explanation. We are not that successful as we see here, high power ablation in US. We don't. I think it has to be the body mass index and so on, many things different. Yeah. So those influence. Okay.
Already 8.
Time's up.
Yeah. Thank you very much.
Thank you.
Just one slide.
Just one slide. That's it.
You prepare some of the slides.
This is the case of a 31 years old complainant history or AMI, and then that's mid RCA, August 2025. Blood pressure is within normal. Body weight is 83. Height is 170. BMI is about 28. And echo show regional warm motion abnormality compatible with the RCA recovery. Ejection fraction is about 52%. E prime is normal. And also very gauge show BBC.
31 years old. Oh, God.
And also CT had shown non-operative stability, beta stent, and MRI had shown probably ischemic cardiomyopathy, and hypoglycemia and warfarin at the interoceptor and inferior segment of APK and therapy. This is the test statement. We did EP study and ablation. BBC originated from RA posterior superior process. And successful ablation of BBC from BBC originating from RA posterior superior process.
Okay. That's great.
Okay. Thank you.
Great. Let's go.
Recording. 네.
Good morning, I'm Junyoung from 7th Hospital. Today I will present the EGM case for orthodromic brain cardiac enrolling 2 test. It is a 29-year-old male with past medical history. He had an episodic dyspnea and palpitation for few years 3 episodes per year, and with the southern onset. Regular narrow QRS tachycardia was documented at an outside hospital, and he was referred for EPS. This ECG shows a regular QRS tachycardia rate of 153. And this is the baseline sinus reading ECG prior to the procedure. So it suggests the left lateral accessory pathway. Chest X-ray was unremarkable. And echocardiography showed the normal chamber size and normal LV systolic function with the ejection fraction 60%. There was no structural heart disease. So we proceed with the episode. These are RAU and LAU view for initial capital positions. A couple in the RANCS and one for the RB and another for the east area. During catheter positioning on narrow QRS tachycardia was induced. The time we didn't get the good signal. The tachycardia cycle length was 364 milliseconds with the QRS duration is 84 milliseconds. Ventricular extra stimulus advanced the next arterial activation. And ventricular overdrive pacing showed a PPI minus DCL of 73 minutes. In sinus rhythm, baseline interval were length 5-6 minutes, AH 58, H rate 36, QRS duration was 93 minutes. During RB pacing at 400 milliseconds, the earliest arterial activation appeared on the septal side electrode. With the fast RB pacing, the earliest arterial activation tripped to the distal coronary sinus, showing centric retrograde activation. 200 milliseconds was the read blood cycle. During single ventricular extra stimulation test, the VA interval prolonged, coupling shortened, showing a decremental retrograde property. Although uncommon for typical accessory pathway, it suggests the decremental accessory pathway in this case. We also assessed the antegrade AV conduction during their pacing to measure the AV blood length, which shows a 210 milliseconds. Using single arterial extra stimulation test, we assessed the antegrade conduction PLP, and there was no AH jump. So in summary, we induced the narrow QRS tachycardia with early arterial activation in the distal CS during repacing for tachycardia. It shows the decremental property. PPI minus DCL was 73 milliseconds. There was a VAV response and no AH. So this was ORT using a lateral accessory pathway as the retrograde ring with the decremental retrograde property. We mapped the retrolateral mitral annulus with the ablation catheter. We delivered the RF energetic target site. Delta wave disappeared in 7 seconds, within 7 seconds after RF onset, and confirming successful elimination of the first pathway. After that, and we attempt reinduction, but tachycardia was induced by APP and with a different retrograde arterial activation sequence. This suggests the second accessory pathway. This slide contrasts the tachycardia 1 and 2, highlighting the change in retrograde arterial activation pattern. In tachycardia 2, earliest retrograde arterial activation was at duodeca H56 electrodes, that is at the rapid posterior septum. We reset was observed, supporting reentrant mechanism with ventricular participation. And ventricular overdrive pacing with the PPI minus TCL for 54 milliseconds. We did a single ventricular extra stimulation test again, and there was no decremental property at this time. In summary, this was level tachycardia with earliest activation in the proximal CS during repacing or tachycardia. We reset by this refractory ventricular extra stimulus. There was a V response and PPI minus TCL of 54 milliseconds during the ventricular overdrive pacing, and there's no decremental property. We diagnosed the ORT using posterior septal arterial pathway as the retrograde peak. We positioned the ablation catheter at the left posterior septal area. And multiple RF applications were delivered at the left posterior septum. Despite ablation, tachycardia remained inducible. And we then moved into the coronary sinus to target possible into CS insertion. And RF energy was delivered within the CS. But after that, tachycardia remained inducible after both endocardial posterior septal and intra-CS ablation attempt. During this tachycardia, there was LBBB, and interestingly, there was no cycle length change. So again, summary. At this stage, we consider that the retrograde rim might be an epicardial accessory pathway via the middle cardiac vein, possibly with a multiple arterial exit site. Explain the fellow was as target. So we advanced the catheter into the middle cardiac vein to target the suspected epicardial lesion. RF region. RF was delivered in the MCV, but it also failed. So we also target the CS loop. RF application were delivered at the CS loop. After MCV and CS loop population, tachycardia could still be induced during LBPC. However, the retrograde arterial activation pattern had changed. So, now the earliest arterial activation was recorded at H11, 12, or 13, 14. That is on the right posterior septum. We reset findings continue to support the reentrant tachycardia mechanism. And after overdrive pacing showed a PPI minus TCL over 83 milliseconds, again consistent with the ORT. So we decided to use the reading system and performed high density mapping with the HD grid X. The earliest signal localized to the right posterior segment below the CS hosting, we found this signal. The 3D activation map confirmed the early structural activation corresponding inferior to the CS hosting. So we positioned the ablation catheter at the left side in the right posterior section, just below the result. Energy was delivered to get this target vision. Tachycardia terminate during ablation and was no longer inducible forward, confirming successful elimination of the second S-wave. So after ablation, single ventricular stimulation test showed the decremental retrograde conduction with a nodal retrograde conduction. And we administered the adenosine, which caused the transient erythema with no evidence of oxidative S-wave conduction, supporting successful ablation. And this is the post-procedure incision. Thank you for your attention.
Case. Can you explain why there initially you saw the VA decremental property, but after the lateral accessory pathway ablation, it disappeared?
Yes, I thought that this left retroactive accessory pathway has a decremental property, so very unusual, but we'll carefully, but this shouldn't.
Activation sequence is exactly same.
Yes, I think so.
Same.
I think you're measuring wrong.
Yeah.
Local B. You have to measure from local B to A, not the stem to the A. Okay, let's go back to case. Okay, this is a little bit more confusing for some young guys.
Second question is, you didn't see any tachycycle change during RBB pattern, but the final successful ablation site was the right side, right?
No, I doubt it.
No.
Go the left side. Go this first. Let's look at the EKG first. Okay, it's the important thing. Okay, so you thought that this was, typical left side of axillary pathway. So AVF was wide as delta, AV alamine, and then rest has a little bit of a thing. Now, is that if you look at the baseline of this ECG, that's why you guys need to read this carefully. Where I think is a baseline of the inferior 2-3 AVF is it in the P wave or at the after that segment? Where you draw standard ECG baseline. When you read the EKG, what's the baseline you define? Is that a T wave between the after the T wave or where? If you draw the line there, okay, what is that the first negative portion 2-3 AVF is showing? First 40 milliseconds the delta is negative, not positive. That's the first mistake we did here. Okay. So then you say, whoa, then what happened to AVL? It's positive also, initial, then negative. Okay. So you need to pay attention what you're doing carefully, please. This patient has a two mixed pattern of the RPW here. It's not a straightforward ECG, you might think. Okay. So baseline definition ECG, then you draw the line, and then first 40 milliseconds is the most important in pre-excited ECG because this is not a maximum pre-excited ECG. Okay, it's a golden rule. If you read the paper by John Gallagher, Duke University, when he sent the patient to the surgery early 1980s, he emphasized in his paper about this. So because often surgeons make a mistake. So this is not a typical left side pattern. Okay, that's number one thing. Let's go next. So how do I find young patient doing well, no problem, and then you do EP study. Okay, you put up. I just tell you again and again. If you put a RV catheter in the mid-septum, the wide pacing electrode, your capture field is going to be quite big, even though invariably going to capture right bundle. Okay, even though you don't record right bundle potential, but go look at the EGM. Baseline sinus rhythm is EGM. I think if you have one, what do you think about this? RB12 EGM. Earlier than 3-4, almost very, very sharp local potential. And 3-4 has a far field, almost same time as the RV of sharp upstroke. The gain is too big there. I bet you close the right bundle, this thing. Okay? So please, when you want to do PET SPT case, try to not put a catheter much as possible in a septum. You want to put an apex, fine, below the moderate band, okay? Or lateral wall or base, where you think the pathway is. Or could be outflow tract as well, okay? So it is an important concept that because TPW basically the fusion phenomenon, so therefore competitive conduction between AV, VA conduction, and then pathway conduction. That's your study. And I want to manifest a pathway. I'm not interested in nodal conduction here. You're only going to create confusion. So that's why Mel Shyman wrote a many papers, Jack and all that. Base of pacing versus apic of pacing, VA conduction time. This is an important concept. Okay, let's go. That's the second correction you need to make in your future case. Okay, going. Okay, here. What is the trouble here? There's a left side pathway that you're going to see several different CS EGM. One is that the clear V, nice eccentric earliest point exhibitions moving away. So in the proximal CS, you will see V clear A separation. Okay, that distal you have one connection. Then you say, wow, this is your lucky day. But this one had what happened? This one here, virtually entire CS VNA merged. Watch out these kind of cases. This is not a single fiber pathway. Okay, very important observation. Because also, our reason I say that is that if you look at the proximal CS, where's the early A, negative, positive, negative, right? Initial Q, small q, and then goes to R. And 5, 6, Q, can tell sure, but it looks like a Q. And then 3, 4, positive. Okay, so that means 3, 4, 1, 2 is a P wave is a positive. 5, 6, 7, 8, most likely negative. The wave breaking off from there. Except earliest activation is where you can tell is it 7 and 8 or 5, 6. I can tell 100% sure where it is 8 is early. So then you want to differential pacing here. This was a key point. So I'm sure you did go to left side transductively, right? So this type of case that the unit LB pacing. Please do that. It will make your life much easier. Operation. Okay, you illustrate the V separation a little bit more to the A, then you can see clear cut where is the V insertion, A insertion. Okay? Yeah. This type of case. Because you pace the septum here is a competitive conduction going on through the midline, part of it, midline through the pathway. But I think this is a very robust, very strong connecting pathway because they're conducting very fast. But I think the complexity of a CST EGM analysis is important. Okay? That's make your life easier. Okay. Now the one question I had, okay, is it normal to have a 13, 14 atrial EGM earlier than he said? You got left side pathway, okay? Think of this now. You got his conduction coming up. The lateral wall of right atrium should be the last guy activated. Isn't that what you see during the VA conduction? why the 1314 has an R wave and earlier than subtype A? Something wrong here, right? It's not normal. So fellows, memorize the normal deactivation, okay? This subtle difference make your life miserable. So this is another point lesson here, that why the 15, 16, Q initial A wave, local A, 13, 14 is R. Two waveforms colliding there. Only explanation you have, right? So then, to be earlier than subtype A, and then has a collision there, you gotta suspect, wow, is this something else happening here too? So I think, just doing the case is important, but sit down, look at the EGM, enjoy EGM, okay? This subtle change is very, very important for you, okay? Okay, let's go. So what do you see here? So beginning of onset of a first case, first bit first. For the first bit, yes. You be pacing, right? Then what happened next? Next bit, no CS EGM, just pay attention to this. What happened? Changed. Next bit, little more. Next bit, then settle down. You see? There's a gradual conduction block happening in different pattern, yet VA conduction time relatively same. That means multiple HR fiber. This is what that means. Maybe single metric connection, but could be a lot of fiber branching in the chronic sinus. So it is important that also look at the CS activation EGM changes related to that, which also affect the what? Your look at your first bit of right atrium, 13, 14. That become what? Next, what happened? Not turned around, right? That means right side input is delayed now. But actually, there's a small fragment signal before onset of that. You pointed, yeah, right there. So activation time did not change, only vector changed. Make sense? So I think more fusion, more favors the left side, less the right side. So this is also an important concept. Now, there's one more detail I want to let you know that is important. This is not tachycardia, okay? This is retrograde VA conduction now. Your HIS, unfortunately, doesn't show a 3-4. I wish it showed a little bit better, HIS 3-4. But if you look at the HIS 1-4 versus 1-2, what do you think? This activation makes sense? Or should it be a little bit slower than 1-2? Actually, 1-4 has a small notch in front that earlier than 1-2. That's tiny notch. He say, go to A. Come back to the, a little bit, yeah. Okay? So you say, well, this thing is not even maybe earlier or maybe on time with us. It's also this activation suggests that the fusion. Okay? So if it is coming from all the way to the pathway, I'm talking last 3 bit here. And then you have a fusion of this A going on, but A, the proximal, his 1-4 is earlier, then you should be far field the signal negative. Yeah, that's early. So there's something else invading that higher septum. Probably they're coming from that 13, 14. So I think there's a lot of unusual feature in this tracing when you look at it. Okay? Okay, let's go.
다시 한번 설명해 주시겠어요?
Okay. So you have a pathway that partially conducting right side.
Yes.
Left side is strong input coming through, multiple fiber, and then also nodal conduction coming out. And then it's balance between these three is fighting right now. So as you pace more dominant to the left side, less favor up to the right because nodal conduction being delayed.
Yeah.
This impulse coming this way, dominant coming this way. That's why 1-4 is a higher, wider area. See earlier than distal coming back up from the septum. That's what I mean. So less.
I don't understand the last point.
Less.
How to interpret the 1-4 and 1-2?
1-4 is a wider region,
Yeah.
so you would see more far field signal.
Right.
Yeah, 1-2 is a local signal.
Right.
So far field signal means you're going to see around the all septal area impulse coming from. So you should not be different. Your vector activation 1-2, which come up to the 1-4, should be the same. It's different. So this is an important issue that what the far field can tell you. Okay. So I think this is something that you need to start thinking, okay, keep going. That's basically interesting in EGM now. Take a look at it. What do you see here? So you pays first bit went to where? To the predominantly left side and probably also the right side a little bit. Okay. Next one. Predominantly left side, still right side a little bit, right? Earlier than he said. Okay. But then look at the EGM, right atrium EGM. What happened? Start splitting, probably because of colliding more to the left as well. And then next one. Now what happened? Septal A become earlier than right atrial. The EGM changing now, becoming completely different change. That's it. So those things will a little bit help you to understand a little bit better. Okay. Now, narrow complex. What happened? That's a normal pattern activation. It's diffusion. Okay. So I think this narrow complex right atrial pathway is bystander, doing nothing. Look at the EGM, change it completely. Sharp A. Is it that A? Retrograde A? There. Yes. The tall R. So I think it is something that came back up together. Right side edge of the left side. That's a fully manifested ECG. So you remember that EGM, okay? Let's go to the last section where the tachycardia induced. After the ablating, all that became right side, more right side. Actually, it's not a right side. I think it is still posterior septal. That's what I think happened. Because you did not do CS venogram, right? You did not do CS venogram in this case, did you? This is a case that you guys need to do CS venogram. Okay? Because of, I think a CS anatomy would be elucidating far more clear idea about this. And I don't think this is not a right free will pathway. No, it's not a posterior septal. Your last ovulation in image, I look at it. Go take a look at the last image. It looks like almost a CS floor os or MCV os. I think that's what MCV is. Often MCV is more osseous than you think. Image, X-ray. X-ray, I can tell you. Yeah, right there. You see? 1, 2, 3, 4, 5, 6, 7, and 8. You're right underneath it. Okay? So I think that's a CS os. Also, the reason I tell you, your septal, his plane is a septal plane, okay? I look at the septum. You're pointing to the septum. So this cannot be posterior, it's a posterior septal by definition. Okay? So I think this is a case where you had a multiple fiber, it's the posterior lateral posterior septal pathway coming out, and you're chipping away one by one. That's what you did. And then the last side had an exit toward the right, posterior septal area, posterior area more than left. So I think a posterior septal pathway, posterior pathways, sometimes it's worth doing CS angio, make sure there's no aneurysm, something bizarre. You even ablate inside the CS, but then we cannot exclude the possibility of CS anomaly. Your CS ablation that you did, I think you ablate the posterolateral branch. You go before that, looking at the X-ray. I think not that one. That one. I think you're ablating posterolateral branch. Yeah, not the posterior sub MCV. I don't think that's MCV. Too far in. Okay. In lateral view, you're looking at the down. Also, in lateral view, you're inside the CS already, probably just beyond that. So maybe flow the CS, and it's hard to know. So please consider doing CS angio next time. Okay. Even patient have such a complex CS insertion, probably you want to understand CS anatomy. If you look at the Hiroshi Nakagawa and Jackman's illustration of right posterior septal anatomy, there's an elegant study published in Circulation. CS musculature virtually merged with the flow of the left atrium first to 15-20 millimeter of the proximal CS. That's why EGM can be so complicated like this. So those cases, CS and might have an aneurysm overlay right at the juxtaposition. And this is the kind of case that also you can develop complication of occluding posterolateral branch of the RCA. Because RCA PDA comes down, posterolateral branch cross to the crux, and it comes to the small portion of the left ventricle. So when we used to ablate posterolateral septal pathway, we did a lot of damage to people. We did not know that too. And then when I went to Sonny's lab, and then he did a routinely pre-ablation RCA angio. I said, why? And he showed me his data. Over 100 patients dexterity, they published over 70% of the injury to the artery, small branch. They don't manifest acute hemorrhage, unfortunately. And he confirmed that after the also follow-up study. So it is something that you need to think about. Okay. So I recommend right corner angiography for crux PVC ablation if you decide to ablate MCV or those area of the right septal posterior septal.
How do you know whether this, by just looking at the X-ray, whether it is not MC?
Because if you're LAO, you're left toward to that his bundle. It's a septal plane, right? That's the supposed way the CSOS a little more posterior to the right.
It should align with
Right. Your X-ray in the we use for area LAO view is a relation to the CS and then his bundle, which is septum. Supposedly his and the CS should be 90 degrees, correct? So if you want to view the septum area view, you should see CS at the line, his bundle wide open. Then you will see 4 electrode space, his perfect, without distortion. You're right angle. That's the angle you map the slope pathway, septal pathway. And then you want to go to LAO, his bundle coming at you. That's a right angle. So there's no defined angle for right person, okay? You have to find during the procedure. As I said, heart differ every patient. So I don't say 35 degree, 40 degree set. That's nonsense. So first thing I teach for my fellow AV and RT ablation, how to set up the floor right. That's what I do. So they often appreciate that. Of course, if you do stiffer area LO, you will get radiation exposure more. That's for sure. Professor Ram teach you a lot about that. So, but hey, I want to fluoro less. Few burn, I'm done. I don't want to keep fluoroing, keep burning again. So that's the, you can think about those balance issues. Okay. Yeah.
Not only the fluoroscopic imaging, but also you can differentiate by electrogram
Yes.
and impedance. I never ablated inside of MCV. Very risky.
Right.
And the Wilbur, the published paper,
right.
David Wilbur, if it is left side septum, he recommended within 1 centimeter of proximal CS, you can ablate, but the successful site is mostly the transseptal posterior septum.
There's only one, I think, SBT that we think you need a muscle ablation at the CS a little bit deeper would be AVNRT, which involve left posterior extension inserting the CS. Okay, that's a distinct tachycardia. But then those one, you exclude all other insertion, make sure that that's the one. Okay. But other than that, Dr. Park says and that's why CS angiogram is important. When you do angiogram, you see pulse and then within deeper, you must map the left posterior septum, right posterior septum, CS, and then you decide what to do with. That would be the best option. I think that reduces the number of RF application, and then you can appreciate your mapping process, EGM. That's how you learn. Yes. Without doing, you won't learn. You gotta do it. Yeah. So if you do few like that, then you have a better idea next time what to do. Then you can go into the target set. Yeah.
Dr. Huang,
Yes, sir.
Senior.
Yes.
Still, I have a curiosity why their tachycardia with RBBB did not probe tachycardia.
Well, because they're not involved in the RB RA junction.
The remaining accessory pathway insertion was RB side, right? As you already mentioned in the lecture.
I think is right at the posterior CSOs. That's what I think. That's why.
So Kuhlmann's load can differentiate the right side, the left side accessory pathway.
Except
if it is very close septum.
The posterior septum, you cannot.
Yeah.
Same way, like having junction rhythm. Your PXI all disappear. Junction rhythm. So that's no use. Okay. So reverse of junction rhythm is a Kuhlmann's law. But There's many debate about the Kumail's law. Last international conference, a Malaysian fellow presented the reverse Kumail's law. Actually, he also measured wrong. I did not want to talk about that. You know, most common mistake, we measure stream to the A. No, we local the A time, okay? Nothing at the stream to the A. Because this patient, septal patient, took a long time to get to the each time decremental conduction. So decremental conduction happened within the ventricle, not in the VA time, okay? So don't forget that, please. Yeah, don't think that all these decremental. So that's why I was looking at all of that. It's not right. So if you look at the node ventricle part A, so all those important to measure local to the A, okay? Then you can say, oh, this may be node ventricle. Nothing wrong have a PGRT that side. We've seen PGRT from left side as well. But again, local time, not the stream to the A, okay? Stream to the A, there's a lot of in between.
So today we'll learn the exception of Kumail's law.
Well, I can teach you on those things, okay? New stuff I don't know. So, but I think it's a very interesting case, very educated case. Thank you for presenting the case. Yeah.
Chunyoung's last presentation. It's wonderful.
Yeah. Enjoyed it very much.
Could you send this file to me by email? Yeah.
Anybody has any other question, please? Okay.
Okay, thank you very much.
Thank you.
Yeah.